Dear friends, ladies and gentlemen, good evening. First of all, I would like to thank the chairman, Professor Renhua, for his introduction of mine. I'm Dr. Lu from Department of Nephrology, Renhua Hospital, Shanghai Jiao Tong University School of Medicine. I once studied in International Renal Research Institute of Vicenza for 1 year as fellow in 2014, and Professor Renhua is my mentor. In addition, I'm very sorry that I am unable to discuss with experts online because I am currently participating in the first line of COVID-19 prevention and control in Shanghai. Today, I would like to share Shanghai expert consensus interpretation of clinical application of hemoperfusion in maintenance hemodialysis patients. First, let me introduce the consensus development process. It takes 13 months and held 3 larger-scale expert consultation and finalization meetings. Well-known experts from Shanghai and China participated in the formulation of this consensus. With reference to domestic and foreign reference combined with clinical diagnosis and treatment experience, a consensus on the clinical application of hemoperfusion in MHD patients was formulated in terms of indicated patients, treatment frequency, treatment mass, adverse reaction, and precautions. Next, I will introduce these 4 items respectively. The first item is indications for hemoperfusion. MHD patients have the following clinical manifestations they recommended to the HP treatment: severe uremic pruritus, severe uremia-related sleep disorders, protein energy consumption, microinflammatory condition, severe SHPT, severe hyper-beta-2 microglobin, refractory hypertension, restless leg syndrome, and uremic peripheral neuropathy. I will explain each of these indications in the following slides. The first indication is severe uremia pruritus. As we know, the uremia pruritus is one of the most important problem in MHD patients, and hemoperfusion may improve the symptoms in these patients. If the modified dose pruritus score more than 12 or the VAS score more than 8, it's recommended to start HP treatment. The modified dose pruritus score, including the degrees of inching, location, frequency, and number of attacks, disturbance to sleep, and so on. The score range from 0 to 40 points. The higher the score, the most serious the pruritus. VAS score 0 means no pruritus, 0 to 3, mild pruritus, 3 to 7, moderate pruritus, 3 to 9 means severe pruritus, and more than 9, very severe pruritus. The second indication in severe uremia-related sleep disorder. A Pittsburgh Sleep Quality Index, PSQI, more than 10 points, it's recommended to start HP treatment. The total PSQI score is 0 to 21 points. Those with the total score more than 5 points have poor sleep quality. The higher the total score, the worse the sleep quality. The third indication is protein energy consumption. Modified quantitative subjective global assessment score, and the MIS means the malnutrition information score were used as evaluation criteria. The total MQSGA score is 7 to 35 points. The higher the score, the worse the nutrition status. The total MIS score is 0 to 30 points. The higher the score, the more serious the degree of malnutrition and from inflammation. If the MQSGA score of MHD patients more than 20 points or MIS score more than 18 points, it is recommended to start HP treatment. The fourth indication is microinflammation states. If the hsCRP persisted more than 3 mg per liter, CRP persisted more than 8 mg per liter, interleukin-6 persisted more than 16.2 pg per milliliter, and the TNF-alpha continues to be more than 14.1 pg per milliliter, it is recommended to start HP treatment. Exclude the infection, the history of malignant tumors, and so on. The fifth indication is the SHPT. If the patients with severe SHPT that cannot be controlled by medical treatment, and the IPTH persisted more than 600 pg per milliliter, the HP treatment should be started. The sixth indication is severe hyper-beta-2 microglobin. As we know, the beta-2-mg is a media molecular toxins, and the accumulation may cause the carpal tunnel syndrome. If the blood beta-2 microglobin more than 13 mg per liter or combined with the carpal tunnel syndrome, it is recommended to start HP treatment. The seventh indication is refractory hypertension. MHD patients with adequate dialysis and dry weight up to the standard use 3 or more different types of antihypertensive drugs. And when each drug reached the maximum dose or the maximum tolerant dose, the systolic blood pressure before dialysis continued to be more than 160. It is recommended to start HP treatment. The eighth indication is restless leg syndrome. If the severity scale score of the patients more than 11 points, it is recommended to start HP treatment. The total score 0 points is none, 1 to 10 points mild, and 12 to 20 points is moderate, and 21 to 30 points is severe, and more than 13 points is extremely severe. The last indication is uremic peripheral nephropathy. Numbness of the extremities, the weakened or disappeared muscle tone or tendon reflexes, and peripheral nerve electrophysiological examination shows that more than 2 nerve abnormalities are involved. It is recommended to start HP treatment. Those are the 9 conditions in which HP treatment recommended. So the next question is how to So the next question is how do you choose the frequency of the HP treatment for those indications? Develop individual HP treatment frequency based on the patient's complications and their severity. Severe uremic pruritus, they recommend the consensus recommended 1 or 2 times every 2 weeks. Severe uremia-related sleep disorders, PSQI score more than 10 points once a week, 5 to 10 points once or twice every 2 weeks. Protein and energy wasting once a week. Microinflammatory condition, 1 or 2 times every 2 weeks. The severe SHPT once a week. Severe hyper-beta-2 microglobin 1 to 3 times a week. Refractory hypertension 1 to 2 times every 2 weeks. And the restless leg syndrome once a week. Uremic peripheral neuropathy once a week. In our hospital, in Renhua Hemodialysis Center, almost all patients with those conditions received HP treatment at least once a week. So how do we recommend HP treatment for patients who have no complications, such as those they are just starting hemodialysis treatment? The experts group suggested that the patients without dialysis-related complications are recommended to undergo hemoperfusion once or twice every 2 weeks to prevent the occurrence of long-term complications related to dialysis. The advice on treatment prescription. The treatment mode, HP can be combined with low flux HD, high flux HD, and hemodiafiltration. The blood flow during treatment, when the HP is combined with HD or HDF, it should be controlled at 115 to 215 milliliter per minute. The connection methods, it is recommended to connect the hemoperfusion device in series in front of the dialyzer or filter. In addition, HP can be started 2 hours after the start of treatment or 2 hours before the end of the treatment. The final part of the consensus is about adverse reactions and precautions. The adverse reactions of HP include abnormal biocompatibility, absorbent partial embolism, air embolism, coagulation disorder, and hypertension. Preventive measures include observe the patient's blood pressure, respiration, heart rate, and other vital signs during the treatment. Pay attention to whether the circulatory circuit has clotting or leakage. Regularly check the blood routine, coagulation function, and other indicators. The following conditions do not recommend HP or suspend HP treatment. The platelet count less than 16,000, white blood cells count less than 4,000, hypertension means pre-dialysis blood pressure lower than 90/60, the active bleeding, and unstable hemodynamic and vital signs. Take-home message. HP has gradually become one of the treatment modes for MHD patients. The effectiveness of its combination with HD or HDF to remove protein-bound toxins, prevent long-term dialysis complications, improve quality of life, and improve long-term prognosis has been initially confirmed. However, regarding the timing and the frequency of HP treatment, more high-quality evidence-based study still need to be clarified so as to provide evidence base for the application of HP in MHD patients. This consensus further clarified the clinical application value of hemoperfusion in maintenance hemodialysis patients and provide guidance for the reasonable and standardized treatment of hemoperfusion in MHD patients. The consensus provided the therapeutic aspect of HP, HD, or HDF combined with HA130 treatments on dialysis-related complications and the prevention of long-term dialysis-related complications. It provides strong supporting evidence for clinicians to practice and will be beneficial to the development of Jiangfeng HA resin hemoperfusion device. Finally, I would like to close my presentation with a viewpoint of my mentor, Professor Ronco. Absorption technology may be the future of the blood purification. That is all what I want to talk about today. Thank you for your attention.